So let's do some, I always start with range of motion, so flex forward at the hips. No, stay seated, yeah. Any pain?
No.
Okay, go into extension, so chest all the way up to the ceiling. Any pain?
No, not there.
Okay.
Like that.
Let's turn and look over left side. Any pain?
No.
Okay. Turn and look over right side.
A little bit.
Where? On the left?
Yeah, right in there. Not so much. Where I feel the pain is a little higher.
So this is always a good thing to clarify. Is that the pain that you're seeing me for today?
No.
Okay, so we may have something going on with facet joints, because remember, when we turn this way, what happens to the contralateral facet joints?
Compress.
They close down, they compress. And so we may have a facet thing going up higher, but either the pain from this, because of pain gate theory, the pain from this is basically that's what his brain is focusing on, and so you don't feel the other pain, or it's just not significant enough for it to actually affect his day-to-day, excuse me, because he's rarely ever in this extreme position, right? Okay, let's lay on his back. Alright, nice and relaxed, nice and relaxed. Any pain?
Yeah, it's a little bit more, yeah, I would say I'm feeling that posterior hip pain when you do that.
And is that posterior hip pain, how does that fit into what you're seeing me for today?
I felt that pain in the back for just a moment though. During when you were bringing it up.
Okay.
It was elicited, but it didn't stay. Just for a moment.
The low back, you're saying?
The low back, yeah.
Stay relaxed. Let me know if it happens again. Nothing?
No.
Okay. I'm gonna bend the knee here. So we had straight leg raise, now we're gonna go into Faber. Take a deep breath and relax. Always have them breathe and relax, because there's so much guarding on the adductors. Any pain here?
No.
And then apply load. Any pain here?
A little bit.
And is that the pain we're talking about today?
Yeah.
Okay. So patients like Alan are who, it's that, what is that in TCM, the more lanky types? Do you remember
Wood.
the wood type?
What type?
Your more wood type patients or your lankier patients, they're generally going to have more joint play. They're generally more flexible. And so if I hadn't of, because this is, you'd think if he's got SI and this is going to be positive, like look at this range of motion. But if this is not stressing his end range of motion, then we're not going to get a good test.
Mm-hmm.
That's why applying the pressure is important in that situation. Check flexion, anything here?
No.
Okay, and then come into,
And the anterior hip, but not the posterior.
Okay.
Yeah.
and then fader, anything here?
No, not on the back.
Okay. And we'll just run through this side, nice and relaxed. Any pain? Okay, we're gonna bend the knee, relax. Any pain? Any pain? Okay. Anything here? Anything? Okay. So then we can check let's say you scoot towards me a little bit. These are one. Oh, sorry, that way. Yeah. This is come off. Anything here? This is a modified CHEMS test, but you'll also get some SI involvement with it. This is really great for your elderly patients where they have very little range of motion, because this is the least sensitive test for any extension in the low back, because this will cause some mild extension in the low back, but not a lot. So I would never, even if he had facet stuff, I would never expect this to be positive on him. It's more so like your 60, 70, 80-year-old patients. And we can come and check Gainsland's here. Any pain here? Okay, I'm gonna apply pressure. Any pain?
No.
Okay.
That's left-sided, Kingsland's.
Technically, yes, left-sided. Even though, remember, because you're getting a rotation and a counter rotation on both tests, it'll be, you can get a positive on both sides.
But for charting purposes.
Yeah, for charting purposes. This off. Anything there? In here?
A little bit
On the left side?
on the left side, yep, in the back and the front.
Okay, and is this different than what I just did, flexion at the hip? Because you didn't have that on the back, correct?
No.
Okay.
It's my, yeah, it's tough because I think the anterior pain's a little louder.
Okay.
So it's, but it was a little different. That did cause just a little bit in the back.
Okay. So even though that's not a true positive for Gainsland's test, we know that we're getting a rotation in the SI joint on his left side with that, and so that still factors in for me. All right, let's go to our thigh thrust. So remember, your hand, the thenar and hypothenar eminence are going to go on the sacrum. Your middle finger should be running up the SPs. Come up here and inferior drive. Any pain?
But yeah, a bit in the
Okay.
back.
And that's the same area that we're talking about?
Yeah.
You always want to be confirming that it's the area that the patient's seeing you for. Anything on this side? Okay. And then we have our, I'll do it from the side, SI joint distraction and compression. So remember, the action that you do is the name of the test. So distraction is going to be, so ASIS, ASIS, any pain? Okay, and then how do you lay on your side? Bend the knees. Good. Remember with this, make sure they're stacked. You don't want them rolled back here, you want them stacked. You're going to find iliac crest, and I drive towards the belly button. Because if you drive towards the belly button, this is your axis, and that axis is going through the SI joint, right? So here, any pain?
No.
Okay. And then flip to the side.
How often do you see SI compression or distraction being positive?
Compression or distraction, rare. I think I've had like 2 positives in the past year and a half that I've incorporated these tests, or you can set up actually. And compression, maybe 10% of the time that there's SI involvement. So, yeah, pretty low compared to your Gainsland's favor and thigh thrust. So usually those are the 3. And then palpation. So SPs, anything along the SPs?
Down there.
And is this familiar?
It is. It's just it's there. That's closer to where the
So
finger feels.
what happened there? You want to turn so they can see. Yeah. Thanks. Yeah. Can I pull this up?
Yeah, absolutely.
So first palpation was here. When we were down here, he started to notice that he was feeling a little bit. When I did this, which was slightly going lateral, now I'm on the sacrum and he feels it. Remember, your ligaments for your SI joint attach sacrum to ilium. So if you're palpating the sacrum, and that's recreating some of their pain, then you know the posterior sacroiliac ligaments are involved. And then here's our PSIS, so any tenderness. And is this the area that you feel pain?
Yeah, and more so right in there.
Okay,
Yeah.
so that's SI. So, sacroiliitis on the left side.
Left side. Come on, left side.
But you see how we kind of worked through using the history first to kind of orient what we're looking for, and then the physical exam for, okay, how can we hone in what we learned in the history to be really specific. So a case like this, I wouldn't feel the need to do like DTRs or wet cold sensation for dermatomes because I don't think there's a dermatomal component, and that might just lead us astray. So, yeah.